Welcome back, everybody, to Happy Health Hour. I'm so happy that we have tens of thousands of viewers of this podcast and hundreds of subscribers. I am really, really happy. And although the gang may not look happy, they are happy too. They just hide their happiness really, really well. The gang is here. The gang is here. Two of them are showing their happiness, their eagerness, and their happiness. And the third is wearing a shirt with Mirror on it, and I will just explain. Mirror is one of the companies that Dr. P is the leader of. So that's what that
It's
shirt is.
it's a pun. It's a pun. Have you ever looked inside one? If you look at one, then you will realize all the flaws that you have.
In a mirror?
In a mirror. Ah, in a mirror. Okay.
The literary minded would catch it immediately. Those who are not literarians, more who live their life on some concrete terms only, who have no imagination, will not understand.
See, I don't.
Slugs?
I
Oh,
fail.
Slugs?
Okay,
Is that a
I
shot across
I
the
think
bows?
on that note, I'm moving quickly to the podcast
It
because
comes from the
I don't want
Greek
to lose.
word "meros."
I do not want to lose the 60, 70,000 viewers we have on our podcasts. So I'm gonna get away from the puns and move into your actual area of expertise, which is Happy Health Hour, Healthcare Hour, Happy Healthcare Hour. This week's episode is transitions of care, where patients fall through the crack. The wisecrack, because of your wisecracks, Dr. P, I'm going to start with you. What do we mean exactly by transitions of care and patients falling through the cracks? What do we actually mean? Put some medical terms around that, would you?
I'll give you very common sense scenarios. Whenever there's a shift, whenever there's a significant shift, if you're living at home and suddenly you start living in the nursing home, in an assisted living facility, if you end up in a hospital, now if you're in the hospital and suddenly you're going home, these are all transitions. These are all changes. And these are important because suddenly something about your health has changed. That is why we are changing the setting, changing the treatment, intensifying it, reducing it, making all the modifications in your medications, getting therapy, some wound care, surgery, all that stuff is needed. So we need to be very attentive to these shifts that are happening in your status first. Obviously, something important happened, and then the medical profession did something. And now it has to be continued, or your old treatments have to be changed or modified, or you may need additional help. That is a transition of care in a very simple way. Patients going from the hospital home after surgery, that's a transition of care. It is critical to understand that, and since we're talking about most, people are listening to it, critical to understand that the best manager of your health is you, is your family. Best manager is be empowered, learn to start keeping records, take a diary, doesn't cost too much, or a notebook. And when you see a doctor, when you have discussions, write them down, simple things, and organize yourself. If you take 40 minutes to get your face done or hair done or pick up your shirt, well, you can spend 4 minutes to take care of your health. So that is what I have to say, because no one is more interested in my health than me, or should be, hopefully. And I need to organize it. When I go and see a doctor, I think the doctor knows everything about me. I have news for you. No. They are looking at their notes. They're going back, unless it's a doctor who knows you for years or is really close to you, develops a bond with you, has a great memory. then it's different. But otherwise, they're also reviewing their charts. You know yourself more intimately than anybody else. So please spend that. And I'm not talking about great Excel sheets, or I'm not talking about great software. I'm talking about a simple pen and paper, a diary, what we used to call a diary. That comes from the Greek word or Latin word diarios. I just wanted to throw that in. And write with old-fashioned pen and paper, pen and pencil, and review it with the doctor. And when you're going home after a procedure, please have your families be involved. These are the medicines. You annoy people, annoy the doctor, annoy the nurse, just a little bit more, extra 25 seconds to make sure things are done right. So many things. 40% of readmissions happen. You go home, 40% time you'll come back. You know why? Because you didn't get the medicine right. 40%. I mean, this is fixable. The third biggest cause of death in our country. Do you know what that is? Not heart disease, not cancer, not some great infection that came. It is, I'm sorry to say this, it hurts my feelings. It is our medical care. We did something wrong. All right, Linda, sorry, I will pass it on to you.
Okay,
Well,
Linda, feel free to interrupt. Go ahead.
So I've been in many different levels of the healthcare continuum in my 8 million years of being a nurse. And for 13 of those years, I was a home health nurse and I was the admissions nurse. So I was the first person to see the patient when they came home from the hospital. I was either there the day they came home or the day after they came home. And the single most important thing that I did, no matter what it was, whether I was putting in a PICC line or a midline or doing wound care, whatever it was, the single most important thing I did when I came into that house was bring me all your medications. I want the shoe boxes. I want the
Yes.
stuff that's in the drawers. I want every medicine cabinet. Bring it here. By the time I leave here today, you will know what you are taking and what you aren't taking. The problem is this. Patients want to go home. They want to go home.
Yep.
Whether they're going home from a rehab hospital, an acute care hospital, a nursing home, and wherever it is, they want to go home. The discharge planner, who is also a nurse in most cases, the case manager, comes in with all the paperwork, goes over everything with the patient, and the patient says, yes, I understand, yes, I understand, yes, I understand. Why? Because they want to go home, and they don't understand, and the family doesn't understand. And then now they're home, and if they don't have home health and a nurse coming in that day or the day after, they're taking 3 different antihypertensives because they don't know what they're supposed to be taking and don't know what they're not supposed to be taking. That, to add on to what Dr. Singh was saying, is probably the most dangerous part of that transition, going from an acute care situation to home. Patients who want to go home, yes, I understand everything, and no, they don't, because they want to go home.
And they
So
may be
you're-
confused. They may be confused and under the influence of the drugs. They're not feeling too well. They cannot pay attention. Or the nurse didn't have a good day. She didn't have her coffee that morning. Or just so many things happen. And and I must say, sometimes we as the medical profession, we presume doctor just writes it thinking the nurse will explain. Nurse just writes it thinking the aide will explain, and aide just shoves it in the bag and no one explains it. Besides, even if they explained it, the patient forgets. By the time a patient walks out of my room, and this is not a reflection on me because I'm the best, when they walk out of my room, they've already forgotten 70% of the things that I said. I've forgotten 90% of the things I said. They've forgotten 17. By the time they walk out of my office, they do not remember 90% of the things I have said. This is studied. So I just wanted to say that. Sorry, Dr. Maria, you have a lot of experience with this because you have been a caretaker, very hands-on, and we all have been caretakers. We all have been patients. Please understand, put yourself in the patient's shoes or the patient's gown, and experience that. Don't just be a high level priest who's just sprinkling the holy water on the patient and walking away. Sorry.
So, Dr. P and Nurse Linda, just, should we try and remember each other's handles? It's Dr. P, not Dr. Singh, and it's Dr. M, and not Dr. Maria, because I like the handles, and the viewers like the handles, as our viewers like the handles. But Dr.
That
M.
proves my point about remembering things. We do not remember the things we are not interested in.
That proves it, absolutely. And Dr. M, do you have something to add before I ask follow-up questions to each of you, to the narrative that Dr. P and Nurse Linda had?
Yes, Dr. As Dr. P, are you not interested in certain people on this panel that you can't remember our name?
I'm very interested, but I know the names for 30
Okay.
years. It's very difficult to transition of a relationship on an online medium is not easy to handle. So
I understand your transition problems,
We're all
Dr. P.
going to try and, yeah.
Okay. I could say a few things here. First of all, the whole element of bringing the person from hospital to home or from home to hospital is a big deal. It's not just, this simple movement. It is an upset. It is certainly an upset of a person's balance. Their balance is thrown off completely. They're not in a setting that they're comfortable in once they go to a hospital. And when they go back home, it's still not comfortable because, as was said before, they don't know. But I mean, they can be confused. There can be so much going on. They might be at end of life. There's a lot that's going on in these movements. And some people are so, they're so thrown off by what they're going through. They really need a lot of comfort in both on both angles or both ends of the spectrum, the hospital or the home. They often are not getting it because of either lack of family or lack of staff in the hospital. Could be anything going on in the hospital. I've heard so many stories about hospitals and not having enough staff or people just not being there for the patient. They can be ringing bells and waiting for a nurse to come in, a doctor, and for them it's like it's like a week of time. An hour goes by is a long time. So there's so many elements to look at here. And when there's no real support, which there should be, there is a breaking down. The whole process is a breakdown. It's the falling through the crack thing. It's breaking down of one's spirit. So I like to think that I could be someone, if they come back from a hospital, to be a support, giving them, loving, caring, supportive, everything, and reviewing everything, as Linda said, their medications, and to see if we can do other things for them, something hands-on, massage, just nice meditation, anything that could be, comforting to their disturbance, their imbalanced state. So we have to provide that, and I think there needs to be more of that in that approach, a holistic approach. That's my approach. So let's take care when we're bringing them home or when they're going to the hospital. And the hospital is a very scary place for many people. And it shouldn't be. It should be a much nicer place than it has been, because lately, from what I've seen in the hospitals with staff shortages and other administrative problems and so on and so forth, it's not what it used to be. Hospitals have changed a lot, unfortunately.
I tell you one thing I'm wouldn't mind some clarity on right now is this an administrative problem or a clinical problem? Maybe Dr. P, you could come in on that. Oh no, Nurse Linda was really eager. Nurse Linda, you go ahead.
It's both. It's absolutely both. And it depends on which transition we're talking about. As Dr. P said, any transition is difficult, and the older the patient is, the more difficult it is. So there's the transition of going in, and then there's the transition of coming back. I mean, when you've got someone who just had, bilateral knee replacements, is the equipment in the home? That's both an administrative and a clinical issue. Did all of the things that needed to happen to move that patient from point A to point B successfully happen? And there's a level of trust that has to be there that's sadly in this day and age, it's just not there because there's so many people falling through the cracks. You discharge someone with a bilateral knee replacement to a stilt home out on the beach that doesn't have an elevator. What kind of discharge is that? They may have all the equipment in the world in that home, but they can't get into it. There are so many levels to think about when you're discharge planning. So as you can see, there's the clinical aspect. What are the patient's clinical needs? Medications, medical equipment, oxygen. There's some important stuff that has to be there when the patient goes home. So there's the clinical aspect. What does the patient need and why? And then there's the administrative aspect. Who called the company that's going to deliver it? Who is home to receive that stuff? Who went and got the medications? There's a lot of moving parts here. And so it's not a one size fits all, and it's not just one side's problem. It's communication, and it is teamwork that has to happen to keep these patients from falling through the cracks.
Thanks, Nurse Linda. Dr. P, so you must have some. Can we move on to good practices and the practices that you have found successful in terms of transition? What do you do that works in terms of transitions?
One thing I would like to add to Linda, and then that'll answer your question too a little bit, is interpersonal relationships and communication issues. Fundamental issue in our healthcare system now is there's a divide. More and more, there's a divide, and it's our fault. We have become more technical, more clinical. Please appreciate the pun. And we have lost the human touch. We have lost the engagement. And of course, the system is heavily biased towards entering information in the EMRs. So we have to know the technical side of it, and we have to kind of standardize every patient. So every patient no person is unique. Everyone has to have the same treatment, same plan, same medication. The personal factor is going away. The bond between the doctor and the patient that used to be the hallmark of American medicine in the older days, the family doctor in the community who would visit the family at home, those are gone. I've not visited a home for 29 years, and that's another story, but I will tell you, the world has changed, and as a society, as a whole culture, we have changed. Now, in this culture, what can be done, right? One is improve your availability or access. If a patient has an issue, family has an issue, can they get in touch with you? They shouldn't be calling and being in line for 20 minutes and then being hung up on. We can do a better job at it. Two, if they have an issue, they should have the trust in you to reach out to you. Third, the ability of the provider to communicate with other providers. All providers have to communicate with each other, because surgeon does something, wanted a medicine on, they put a stent in the heart, they want a certain medicine on, the cardiologist did not write it, the primary care doesn't write it, and now the patient goes home, doesn't get the medicine, and 2 days later back with a clot in the stent. Now, that is where communication and engagement, and 99% of this is communication. And we need to improve on that. So if there is the best practices that I've that I would like to think are there, and Linda will tell you how often you will catch up on some mistake that happened. Doesn't matter whose fault, some person's fault, some system's fault, some facts not going through, the pharmacist not giving the medicine, is the patient's ability to connect with someone who has the interest to get the right answers for them. It can be a nurse. Nurses are great because they are compassionate. They'll take care of the person at a very close level with the patient at a deeper engagement. But doctors can do better, and we all need to improve. And first of all, to realize that this is important. And the patients and families have to realize it too. Don't push the system. Don't try to just go home when you're not ready. Do not try to sign out against medical advice. That's never a good thing. You may be very unhappy. Try to fix the problem. 90% of the time, the problem can be fixed and issues can be resolved. So I don't know if I answered your question fully, but I think communication, engagement.
I think you did. I think you did, but it's given me a follow-up question, Dr. M, I suppose. And it's similar to a question I posed in the past, or that we have discussed in the past, and this is about going back several episodes about nutrition, where I think, Dr. M, you told us that there are about 10 to 20 hours of nutrition content in a medical degree, but it's one of the most important preventative things. So similarly here, how much communication and engagement content do doctors receive in their qualification, in their studies? How much do they receive, Dr. M?
Well, first of all, correct you, it's not even 20 to 30 hours. I did mention the last time that this coming fall, the new classes in medical school will have to, be required to take 40, perhaps 40 plus hours of nutrition. And that's a big difference. We got maybe an hour or two.
Yeah.
Which really wasn't any discussion about nutrition. It was biochemistry and maybe vitamin deficiencies. There's a real serious deficit, has been, in terms of nutrition, in terms of how to communication skills.
Mm.
Most physicians, unfortunately, for the longest time, have not been given enough talk or examples or whatever of these kinds of things, as interactions, and how to reconcile, how to put all the pieces together. Nutrition, going back to that, when someone goes into the hospital, their nutritional status drops considerably. Their vitamin levels drop considerably. Vitamin C being one of the biggest losses once they go in. Vitamin D, another big loss, because most people are inside, indoors, not by a window, not by the sun, not going out in the sun. They used to take people outside. In the past, it was done. People went outside in these courtyards and places where the sun can shine on them. And in the past, there were, sunlight was part of the treatment. It's not now. So vitamin deficiencies drop, and so people's immune systems fall apart in the hospital. And then they come home, and if they're not really in the best of shape, they're still lagging with their deficiencies and insufficiencies, and that has to be picked up. These people need guidance. So in the hospital, you don't get the best of food, or if you're not able to eat, you're going to get something through a tube or an IV. And that really isn't satisfying all your nutritional needs. It really isn't. When you need it most, you need to have the right vitamins and antioxidants in the hospital, and they won't allow that to come in. They don't allow these people to bring in their own stuff unless you have special permission by the that, Congress, an act of Congress, you have to get permission. This is a problem.
Yeah.
Nutritionally speaking, these people are suffering in and then outside of the hospital, and then they get weaker unless they know what to do. They don't have the guidance. Doctors generally don't have that, and unless you're trained in nutritional medicine, unless you're trained in the these type of things where we do get the holistic under our belt, and we can share that with our patients. That's what's lacking. It's very deficient, and food is medicine, and nutrients, it's all about it. So when people are losing all that, they get weaker, they don't get strong, then they end up back in the hospital, they don't have the right guidance. So it's unfortunate. But hopefully, we're going to be seeing more and more of this adding to our medical education, more on health and well-being, and how to make it better.
Thanks, Dr. M. You had your hand up, Nurse Linda, but I wanted to ask you a question. Maybe you can weave in what you wanted to say with my question. This seems like such a big problem. The transition of it seems like such a big problem, and the fact that the skills required, communication skills, and understanding what communication to give them, not just in medication, but in terms of nutrition. There seems such a big problem. This is insurmountable, isn't it? Is there anything, words of wisdom that you can offer that we could change? This could change quickly. Just some aspects of it could change quickly.
I think I was a caregiver to my parents in their later lives, and I continue to be thus for all my siblings and their husbands and their children, and so on and so forth. I think the most important thing, as Dr. Singh alluded to before, is that communication with family. Dr. P. I'm old. Anyway, Dr. P. And for 23 years, I've known him as one thing. All right. Anyway, these patients need advocates. They need advocates, whether it's part of their family or a caregiver, a son, a daughter, a niece, a nephew, whoever it is. They need an advocate. And as Dr. P had alluded to before, you have the relationship with the patient and the family. You sort of set that up ahead of time. No one in my family goes to any physician without at some point communicating with me or my husband, just to let us know what's going on. God forbid something has to happen and we have to step in. Anyway, we take care of it legally as well with the medical, power of attorney and all of that stuff. But just to have someone interested enough to take that step, to be there with you, to handhold, to explain not only the transition itself or what's going on in the hospital, where you lose all control of your life and what's going on. You have control. These elderly people just have no control over anything, nor do many of them understand. So in a situation like that, you need someone to be able to cut through the red tape, to be able to understand the financial, all of it.
Leslie, I'm going to cut across you. I'm hearing the problem, but I want to hear a solution from you, because what you're saying is that you need somebody, but I'm not asking that question. The question I'm asking is, but let's say there isn't anybody. What can you offer that's better than somebody? If they don't have the relative that's willing to do that, this is an insurmountable problem, it seems.
That's
my question.
It is not.
Well, then I need you or Dr. P to explain why it's not an insurmountable problem. If you don't have a relative, imagine there's no relative.
Then there is a level of service called case management and social work. It requires, and these people hopefully went into these practices because they had that compassion and that need to do well and to help people through this. There are also advocates, outside of medicine, that there are associations and certain groups outside of medicine that will take on that role. So if you have someone come to you and they have nothing, they have no one, they have nothing, and they're totally lost, it's up to the case manager, social worker who's in the facility or in the place where this is happening to make that connection, help make that connection for that patient. They exist. It's all about communication. It's all about knowing what your resource sources are and putting them together, and not just saying, oh, well, it's their problem. It's not their problem. If you are a good clinician, it is your problem. It is a problem that you have together. And yes, there are solutions. Not always easy. It takes going the extra mile, but there are solutions.
So Dr. P, I'm going to end with you, and I'm going to take a theory from management, and I'm going to pose the question from that theory. It's called the attention-based view, and it's really easy to understand because what it says on the tin is what it is. The attention-based view is that humans can focus their attention on a small number of things. So my point here is really that doctors are doctors. They are clinicians, they're physicians, they are providers of healthcare. Are they also really going to be, by and large, of course, you three are an exception, but generally, are they also going to be the best communicators and administrators that they can do the transition stuff as well? And I think that's I'm trying to get an answer from you about that there seems to be an insurmountable problem because the training and the expertise is in one domain, and when the transition happens, it needs expertise from another domain.
Yeah, so that is one important aspect of healthcare that has been paid attention to. And that is why healthcare is no longer a physician-centered approach. It has become more a team-based approach where no one person, no man is an island. In the old days, what the doctor said happened and that was it. No, that hierarchy has been challenged, and I believe for good cause, because you cannot expect the doctor to be also the best communicator. They should be engaged, they should communicate, but sometimes someone who understands the culture of the person better, someone who understands the language better. Sometimes our languages, we have multiple languages, multiple cultures, patients may not understand. So you need that team-based approach, a case manager, a nurse, and an aide, someone who will work with the patient and bridge that gap. So you are absolutely right. And we presume a lot. We presume that the patients have understood us when they haven't. And often we have to go back and revisit. Also, our patients are 80, 90 years old. They do not retain. It's human nature not to retain. So, but when we become aware of it, then I think we can do things to it. What should we do going forward? One is realize that these transitions of care are important. Going home after a surgical procedure is not, oh, okay, I'm free from my prison, let me go home. There's a lot more involved. Also, the pressure that is put on the system to go home immediately is something that we should resist as patients or as family members. We should ensure that everything is in place before we go home. Today, I had a patient had gallbladder surgery, lost 25 pounds in 5 days, during the 5 days that he was in the hospital. They stopped feeding. Obviously, he had a gallbladder attack. And after a day or two, they just gave him IV fluids. 25 pounds. This is a person who was an exercise enthusiast, goes to the gym 7 days a week, 25. He's weak as a kitten. And so we need to be aware of what things can happen, even through our care, which was necessary. The person had to be fasting, patient had an attack of pancreatitis. There was no other option. They could have given some other kind of nutrition, but okay, maybe they didn't want to. They wanted the person out. And it's in our interest to get the person home too. It is not that we don't want to get the patient home. That's the best setting for the patient. But I think if we approach it as a team effort, and family members, friends of the patients are, in my mind, part of the team. They must be a part of the team. And if there are none, then we have to do a better job at ensuring that there's a safe discharge. We call it a safe discharge because if we get the person home without all the things in place, person will end up falling, fracturing something. Something bad is going to happen. And of course, something that is preventable, that also can happen. So your attention-based approach is quite appropriate. However, we live in an age of ADHD, and doctors are famously doing 100 things at the same time. So we cannot emphasize this more often. This is so important that we need to be aware. And any time someone in your family is involved who is having surgery, please emphasize to everyone that we need to be at the top of our game. This is the most critical time.
Dr. M, you had some thoughts?
Yes, may I add to this? The patients should, and their families should be in touch with the administrators of the hospital. I think this is a very important thing. When they voice their grievances, their opinions, whatever, if they have good suggestions or they have complaints, they should go right to administration. A lot of this is necessary. I see a lot of people neglect to do it or feel bad doing it. I don't want to see jobs, people lose their jobs kind of thing. And I hear this and I said, you must speak up. It doesn't get done if they don't hear you, if there's no movement made. It's the same thing in our offices. If people if they complain, I'm the complaint department. They'll come to me and say, doctor did this, person did that, therapist didn't do this. I get all this. They come in and complain to me. And I said, put it in writing. It will be looked at and it will be reviewed. We have to make changes based on what you're complaining about. If you're not getting the care, if you got poorly treated in the hospital, if you were poorly treated at our office, we need to know because we're all so busy. So the busyness has to slow down and we all have to look when people are complaining. So I think the voice of the people is really what's necessary. They need to let their needs not be known. There's a lot of discontent in hospitals and in offices because they're not being paid attention to. They're not, the calls are not being answered, whatever. We've got to pay attention and make changes. And CEOs of hospitals and companies need to be on the ball with this and teach and train their staff. You've got to pay attention.
I think we're going to stay, Linda, just 1 second, because and you can answer the question but let me bring this point in, because we've been talking about communication, and I want to, again, I'm going to be boring and bring in something from management to management theory, and it's called sense giving and sense receiving, sense making and sense giving, and this is just basically to make sure, how do you make sure that what you've said is how you intended to say it is how it's received? How do doctors, nurses, administrators get the training so that they speak in the way the person on the other end of it, the recipient, is capable of receiving it? Or, as I suggest happens, do they just have their way of saying it? Does everybody just have their way of saying it, and then the recipient may get it or may not? If they're in tune with the way it's being given, they may get it, but if they need to hear it in a different way, they may not get it. Is there any training? I've sort of touched on it 10, 15 minutes ago, but I want to focus on that because all of you are saying it's important. I just want to make sure, how important is it in reality if nobody's getting the training to understand sense giving and sense making? Linda, go ahead.
First of all, I want to say we can't fix what we don't know is broken. So I'm adding on to Dr. M's statement. If we don't know it's broken, we can't fix it. And
Okay.
that's in everything. And as far as the training, I can only speak as a nurse because I'm not a physician. And yes, we have sensitivity training, and your whole psych rotation goes into having empathy and understanding, because in a psychiatric background, in a psychiatric facility, what's going on with them, they see the world differently than we do, basically because of the chemistry of their brain in many cases. And so it's learning how to listen, not hear. Yes, there is some training. Is there enough? I don't know. I haven't been to med school.
Okay. Yeah. What about you, Dr. P? What do you think about the training in your organization? What are people looking? Are people empathizing with the way the recipient wants to receive information, or are they saying it in their way 100% of the time?
So we have seen a shift in even the training in graduate medical education. There's more emphasis on not just on the technical side or clinical side of medicine, but also on the human side, the interpersonal side, the communication side. So it does improve. Transition of care has become very important in healthcare. Post-acute care, we call it. Also, after an urgent issue that is addressed, an acute situation, what do we do afterwards? This is called post-acute care. People are more sensitized to it, more sensitive to it. But I think we have much more to do. We can get better at it. And I think it should become a team effort between the patients and the medical profession. Patient, family, friends, and the medical profession, all working as one team. Because if we all work together, then we have better results, obviously, and we can prevent so many injuries to our patients, and preventable injuries at that. Training is better, but I think we can do much more by spreading this awareness. The system has gotten broken because of the incentives in the system. The incentive in the system, the hospital's incentive is to get the patient out quickly. The doctor's incentive is achieve a certain result and move on quickly. Doctor does the surgery and moves on to the next surgery. People who are taking care of it, what do they do? The incentives have become measurable. However, in that measurability, in that standardization, we have lost the human factor, and we need to bring that human factor back. I think we can do a better job at it by talking about it, by sharing our limitations, by sharing our deficiencies, and realizing we need to be on the alert when someone is going home. It is not just a routine thing. If anyone can, there's one thing I would say is, if your loved one is having a transition of care, do not treat it as a matter, for just as a standard or as a normal issue. Be involved, learn, educate, empower, transform, intervene. All that needs to be done. And it's transformation of healthcare is not a one person's job. It is our job as a whole team, and I'm including patients and doctors. And doctors who are enlightened, who are more aware, more sensitive, will take it as a team effort.
Dr. M, final word to you. It's an extended episode, which we'll cut it. It'll be a part 1 and part 2. We'll edit it into 2 so that it's consumable by viewers. But it was important that we just carry on this episode. Final word to you.
Putting it all together, you know, I like to see things as a whole. We do need to bring in those people, and I'm going to say it, that more spiritually oriented, more you know, empathetic humans who have that gift of being able to touch others. We need more of those types who will be the leaders, who will show and tell all that is needed in the whole arena of healthcare. The medical world needs that touch. They need that loving touch, because people who have it, they know how to transmit that message. They are the ones we need to bring the message to all of the medical community all over the place, universally. We don't have the right people, unfortunately, who are leading the pack. We have a lot of very structural, very type A personality, very money-oriented, profit-seeking type of people, and power in, you know, wanting to control. And we have shareholders in the business of medicine, you know, so it's not what it used to be thousands of years ago, hundreds of years ago, even 100 years ago. But in the past century, it has taken a whole different turn. And I and all of you on this panel would like to see it better and changed. And the only way that's going to happen is when we have the right people in place. They're not there. Right now, it's still kind of everybody's, you know, again, now with the new technology, I don't want AI taking over. I really don't. You know, let's use it as a tool, but we need the spiritually oriented, the people who have that touch and who can say to others and company heads and heads of business in the hospital or wherever, we need to touch our people. They're our family. We're one. We're a whole. We're a big family. Everybody thinks that they're part of different families. No, it's a universal family. You know, I have a partner for life who's from another country. That doesn't matter.
Another planet.
My family.
Lovely. So I just want to applaud all three of you for being risk takers in how you answer questions, so that you can be authentic and real. And I just love that about this show and about the three of you. After the show's over, I'm going to go back to criticizing you publicly and privately wherever I can go. But for now, I'll just speak the truth. It's a pleasure to speak to you on these shows. Big shout outs to because we mentioned them, Carl Weick's theory of sense giving, and Bill Acasio, for his theory on the attention-based view, and for you three for taking those theories of management and trying to apply them to the healthcare sector. Thank you so much, all three of you. This week, though, it's the end of the show, so it's goodbye from Nurse Linda. It's goodbye from Dr. M. And of course, it's goodbye from Dr. P. And from me. See you next time.